Welcome, everybody. Thank you for joining us today for our December MDMA webinar. Before we get started, we have a couple of quick housekeeping items. One, all the webinar attendees will be in a listen-only mode, and we will be using the Q&A feature at the bottom of your screen to take any questions. So please feel free to submit your questions at any time during the presentation by using this function. There is a little icon at the bottom, and the questions will be addressed at the end of the speaker's formal remarks. Today's webinar is being recorded, and a copy of the recording and any available slides will be posted on our website under the online education section of your member center. So thank you again for joining us. Today's webinar is CPT coding updates, 2022 changes and what you need to know. Our speaker today is Joe Rivet, and I'm going to now turn the controls over to him so he can get started. Welcome, Joe.
Great, thanks, Courtney. Good morning, good afternoon, everyone. So we'll jump right into it. We have a pretty full deck here to really go over all of these. I mean, it would take us probably 2 days, but what I've done is I have pulled out really the high points of some of the key changes that have will become effective January 1st for the 2022 CPT changes. This is a high glance at the changes based on the category, what's been added, deleted, and revised. It's always interesting to see where do we see the most movement. And overall, there's been 405 total changes with 2022 code set or rounding out at about nearly 11,000 codes. So the code book is certainly expanding. A lot of the changes you can see evolved around surgery based on advanced technology, pathology and lab procedures, which is a result of the pandemic, along with the medicine services and procedures with expansion of telemedicine, and category 3 codes, which are new codes, again, as a result of both technology and the pandemic, and then also the PLA codes. And I'll dive into these as we move forward, but we're looking at just over 400 changes. I won't go over all 400 of them, more so the most notable ones. Starting off with evaluation and management services, last year with 2021 was really some historic changes that we saw with evaluation and management around the office and outpatient services of the 99202 through 99215, because remember, they deleted 99201. For 2022, there are 15 changes to the E&M category. There were some editorial revisions around care management services, and also a new series of codes in the principal care management codes, which were the 99424 to the 99427, which allow reporting for care management services to patients with one chronic condition. And then for 99211, just an editorial revision. You can see the strike through here on the screen. This is what the AMA editorial board removed for that code description. As a side note, I did send as a separate handout for principal care management and chronic care management, which is just kind of a big grid of the codes, the clinical staff who can perform those codes, the time limits, and then also the monthly duration. If you do anything around principal care management or chronic care management, there has been a significant amount of section guideline additions that are worth taking a look at. And then we have the psychiatric interactive complexity code at 90785. And interactive complexity is defined, it's a defined term in the guidelines. And interactive complexity can be reported when at least one of 4 complexities are present. And those four, and I'm just paraphrasing, is the need to manage a maladaptive communication that can be through related to high anxiety or high reactivity of the patient, repeated questions. Number two, any caregiver emotions or behavior which interferes with the caregiver's understanding and ability to assist in the implementation of the treatment plan. Number three was the evidence or disclosure of any sentinel event or any mandated reporting to a third party. So what we're talking about here is if the caregiver or if the provider has to report any abuse or neglect to a state agency, this would trigger that psychiatric interactive complexity code. And then lastly, any use of play equipment or other types of physical devices to communicate with the patient to overcome any particular barrier for either therapeutic or diagnostic interaction. Those are the four qualifiers in which at least one of them would have to be present in order to support the psychiatric interactive complexity, because it is recognizing the complexity component. The interactive complexity code that you see here has to be reported in conjunction with an appropriate psychiatric evaluation or psychotherapy service. And additionally, the amount of time that's spent providing the interactive complexity service should be reflected in the time service for the code for psychotherapy. Also, you can see here, this is an excerpt from the CPT manual. They removed interpreters, language and translators. That's no longer going to push you into this complexity code. Additionally, the principal care management and chronic care management codes has seen some changes. These codes are excluded with other services. The OAG has issued a few audits that have resulted in fairly sizable overpayments when these principal care management and chronic care management codes are reported in addition to what they call overlapping services. If you are reporting these particular codes, I strongly encourage you to pay attention to those OAG reports and make sure that you're not reporting these codes with those overlapping services in which those other services are inclusive of these care management codes. There are a number of parentheticals in the 2022 CPT book, which lists other services in which the principal care management and the chronic care management cannot be reported with. So they are mutually exclusive, or you could say differently that they're bundled. And again, there's been a few audits recently from the OIG worth taking a look at just to make sure that you have a full understanding of what those overlapping services are. And that's how the OIG has defined it, was overlapping services. There's also a number of changes around the codes, which include significant changes to the section guidelines here, and they cover specific instructions on reporting those codes. Now, given the time constraints here, we probably could talk a good hour really around principal care management and chronic care management codes. There is a significant amount to understand with these codes, how we're reporting the time, which codes can be reported together or not together, and then also who can deliver the services. Again, there was a handout that I included with the presentation that kind of, it was just a very simple grid based on the information from the CPT manual. Some people kind of like those visuals as kind of a helpful reference, but do take a very close look at this section of the manual. Radiology, there were 20 changes across the radiology section, and also inclusive of the category 3 sections. There was a fair amount of changes as we saw in that initial slide around category 3 changes. Here in the radiology section, there's the assisted augmented intelligence analysis. There's some quantitative multi-parametric management resource or resonance, sorry. And then also 3D imaging of the breast specimen, and then some new codes around trabecular bone score, or what is called sometimes as TBS. Those codes are 77089 through 77092. Just so you can understand what the trabecular bone score is, this is a measurement of the bone texture, and it correlates with the bone microarchitecture and a marker for the risk of osteoporosis. So under TBS, this is really a better way in which clinicians can predict or have some type of predicting look forward around fracture risks for patients, and also those with any type of metabolic bone problems. So there are 4 codes which will allow for various components of those services, of those TBS services, to be reported. You can report the entire service. You can report the technical component only for data transmission, also a technical component for any offsite analysis, and also an interpretation of data. So it's somewhat similar to other diagnostic studies where we do have that professional technical component, although this is branched out a little bit more detailed, not just professional and technical, but we actually have 4 options when we're reporting TBS. If you do perform the code and also the interpretation, there's a code for that entire service. Some new category 3 codes. I have listed out those codes here. We have 0673T. This is a new code, which is a minimally invasive outpatient procedure to treat thyroid nodules, and it's reported 1 time per procedure, regardless of the number of modules that are ablated, and the code includes imaging guidance. 0686T is a specific treatment for liver lesions. This is different from other ablative methods, and it does not use thermal energy. What this procedure does, it destroys the tissue using a focused acoustic energy, and this code also includes imaging guidance. At 0689T and 0690T, these can be used to look at the liver for fat content. Also the breast to separate any benign mass from a malignant mass. And they can also use it on the eye for the same purpose. So some new technologies here, which is why they are ending up in the category 3 section. And then lastly, we have 0697T. And there's also 0698T. These are for quantitative magnetic resonance for analysis of tissue composition. So those are the high-level updates for radiology, all pretty significant. The TBS are definitely an expansion under the category 1 codes, because they're permanent codes, and how they're breaking out both the professional and technical with those data components if the study is read elsewhere. Path and lab, huge amount of changes, 81 changes cut across the pathology section. 69 of those changes are around the proprietary lab analysis changes. So the large amount of changes here really was a result of the COVID testing codes that were added, into the official 2022 code set. So we have the COVID-19 neutralization antibody testing, also the SARS-CoV-2 quantitative antibody assay, antigen testing, and also multiplex testing. Those were some of the big ones. We also have monoclonal antibodies that seem to be coming out at a fairly regular pace, and I'll talk about those a little bit later. So on this side, we start off with the new codes for the ANCA. You can also see the mitochondrial AB, voltage, etc. The celiac disease panel codes, which are noted here about the fifth bullet down, there's new panel codes for celiac disease testing, which is CPT 86231, 258, and 354. The celiac disease panel codes actually allow for specificity for reporting these different types of celiac disease testing that they can do around that particular disease. There's also a number of other changes this year in the cytogenomics, including guidance on the use of those codes. Those codes were at 81228, 229, and 81349. And there's a few parenthetical notes that are also added as well. And then there were some revisions with pathology, clinical consultations, and a fair amount of guideline revisions around path and lab. The PLA codes, so PLA are the proprietary laboratory analysis. They have undergone some significant changes, and I've listed them out here. 5 deletions, 3 revisions, those in of themselves not overly significant. But there were 82 new proprietary lab analysis codes, including 5 for COVID-19 test. For digital medicine, I don't recall in the past that the AMA has carved out a section for digital medicine. Maybe they have, and I just haven't noticed it until this year. But they do have a section on digital medicine. There are 10 changes across surgery, medicine, and also there was a new appendix that was introduced this year. So starting off with remote therapeutic monitoring seems to be kind of the movement that has been really accelerated, frankly, by the pandemic. Code 98975 is intended to report the initial setup and also the patient education on use of the equipment for remote therapeutic monitoring. Codes 98976 and 77, those are intended to report a 30-day service supply with scheduled recording or programming alert transmissions to monitor the respiratory system. There's a code for that, which is your 98977, or also musculoskeletal system at 98978. So when you report these codes, you have to understand, one, we have that initial setup code, and then we also have codes that are intended to be reported for a 30-day supply for that scheduling programming, or for scheduled recording or programmed alert transmission. So just a few things to really kind of pay attention to around the remote therapeutic monitoring. For category 3, we have 0702T and 3T. And these are your remote cognitive behavioral therapy services. These have been added to report remote therapeutic monitoring of standardized online digital cognitive behavioral therapy program. With 0702T, this is intended to report the supply and also the technical support for each 30 days. And then 0703T, that is intended to be reported for management services that's performed either by the physician or by the qualified healthcare professional per calendar month. Those services represent an online computer-based behavioral therapy that can be used for various ranges of disorder, including substance abuse. If you have looked through the proposed rule, there was a lot of discussion around pain management, and I suspect over the coming years, there will be more codes available around pain management, which can tie into also, unfortunately, substance abuse. Codes 0704T and 0708T, these are your remote amblyopia treatment. These have been added to report treatments for using an eye tracking device. So amblyopia occurs in early childhood, and this is when the nerve pathways between both the brain and the eye are not properly stimulated, and then the brain effectively will favor one eye over the other. Sometimes this is referred to as lazy eye, but there's a way in which they can do some of this treatment now remotely. Also, rounding out digital medicine, Appendix R is digital medicine service taxonomy. I would definitely encourage you to take a look at these appendixes. Appendix R is a listing of the digital medicine services that are described within the CPT code set. This is a new appendix, and it provides a taxonomy of digital medicine services. It also classifies existing CPT codes that describe digital medicine into discrete categories that are organized by the provider of the service, also the activities that are involved in that clinician work as well. Appendix P is a list of CPT codes that may be used for reporting synchronous, which is real-time telemedicine services when appended with modifier 95. Appendix P is kind of nice because it lists all the codes. You don't have to go find them. Those are all of your codes that are synchronous or real-time telemedicine services reported using modifier 95. Now, kind of the footnote there on modifier 95 is pay attention to your payers as to how they want modifier used, if at all, in some cases. Anesthesia, not a huge amount of changes here. There were some new anesthesia codes for pure cutaneous imaging guided procedures, which is your 01935 to 01942. And it established to provide really clarity for the pure cutaneous procedures of the spine at the cervical, thoracic versus lumbar or sacral regions. So it kind of broke those out. There's also some new anatomical categorizations that are considered within the CPT codes that are related to the spine. And there's no longer a need to distinguish by diagnostic versus therapeutic procedures for those particular codes. And 01935 and 36 have been deleted, but there is a parenthetical guidance that will guide you to report the appropriate codes in place of those deletions. This is also a new appendix Q. You can kind of see it here. It's a little bit small. I just did a little snapshot of this. This is a really helpful appendix for vaccines and administrations. So if you look across the top, you'll have the vaccine code. You will have the administration code that is associated with that vaccine code. It's really critical to make sure that you have edits in place. If you have a vaccine code, that claim should not be dropping without an administration code. There are particular codes based on the status indicators that when they get sent over to the payer, particularly to Medicare, if it is missing, depending on the status indicator of the code, if they are missing an administration code, it will hit an RTP edit, which is a return to the provider, and the claim will not adjudicate. That's something preventable within the walls of your organization through your edit system. The third column will list the vaccine manufacturer. Depending on the vaccine manufacturer, we may have a different vaccine code and administration code. Not all the time, but in some cases we do. And then you will also be provided the NDC number and then the dosing intervals as well, which is really helpful. But I would say primarily those first two columns are extremely helpful from a charge reporting standpoint. There's also monoclonal antibodies. I'll talk about those a little bit later, but I've included some additional references just because it can be a bit of a challenge to try to figure out what codes that we're reporting with these particular vaccines. What codes am I going to be using for a first dose, second dose, booster, so on and so forth. So these grids are helpful. This does run a few pages in the code book, but you can just see kind of a snapshot here. So kind of a helpful addition. There were 28 CPT codes that have been created for the COVID-19 vaccine, both the product and the administration code. Keep in mind that when we're injecting into a patient, we're infusing into a patient, that actual liquid that we're putting into the patient, that's the product. There will be a code for that. The method in which we're introducing it into the body, either by injection, infusion, or some other method, that is the administration code. You need to have both of those together, and sometimes those do get missed. There are 8 vaccine product codes for Pfizer, combination of 8 between Pfizer, Moderna, Janssen, Zestra, and also Novavax. And then we have 20 vaccine administration codes that are per dose. So overall, we have 28 codes. Interesting enough, 8 of them are for products. The remainder 20 are for the administration. So there's a lot that can go wrong here if you're not careful of how you're reporting those. CMS will maintain the current payment rate of $40 per dose for administration of the COVID-19 vaccines through the end of the calendar year in which the public health emergency ends. The additional payment, there's $35.50 when that vaccine is administered in the beneficiary's home under certain circumstances until the end of the public health emergency. So there is this additional payment opportunity for vaccines that are given in the patient's home. If you go to the CMS website, to their vaccine page, which I have listed here, it's actually the third bullet down. I believe it's on that page. They talk about the additional payment when the vaccine is given in a patient's home. They do define what the patient's home is, and the conditions that have to be met, because there's some qualifying circumstances that have to be met in which there's participation in a particular program, and then no more than 10 vaccines. And they give you some examples of how to trigger that additional payment. There's also a couple other websites here from the AMA around the COVID-19 related CPT codes, which the first one will include all of your lab diagnostic tests, also your supplies as well, and then vaccine-specific CPT codes as well in that second bullet. So definitely a lot around that category. Neurosurgery and spine, a few changes here. We start off with the intracranial laster interstitial thermal therapy. We refer to it really as LIT. Two new codes here, your 61736 and 61737. With a LIT procedure, what's happening here is an injection is done in the scalp. We're essentially going to be cutting a hole into the scalp in through the bone. So they're injecting into the scalp. The physician will perform a twist drill craniectomy into the skull, and a cannula is actually going to be placed and open to open the dura in the pia portion of the brain. And then a rod is placed under fluoroscopic guidance. A software is used to really help target the boundaries. Also, the temperature point of reference that's going to map out the particular target area, because what will happen is a laser will deliver a thermal dose, which is targeting a very specific area, which is the lesion deep within the brain. And so that is what they're doing with this particular procedure. The RVUs for this code, as you can imagine, being in neurosurgery, are fairly high. They are 19.06 and 22.67 RVUs for those respective codes. So two new codes in that area. There's also an add-on code for arthrodesis that was established, and really the introduction of the add-on code was to allow for the to appropriately identify the decompression that could be separately reported. So sometimes you will need to do that separately. And then also we have the destruction of the basic vertebrable nerve. This is going to be treatment through L3 through S1. So that is in the lower part of your back. So it's treating those vertebrae. And the purpose of this nerve destruction is to help relieve chronic back pain. Moving into cardiology, again, there was a fair amount of changes here for cardiology. There were 35 changes across cardiology and interventional cardiology. One of them being the 3D or the three-dimensional imaging of cardiac structures. So you have 93319. This is an add-on code for real-time 3D echocardiography. Through this 3D method, the visualization of what they can see through that 3D imaging versus 2D is quite significant. You report the transthoracic code for the congenital heart defects with 93303, and you also have your 93304. And you report those both with the standard and congenital transesophageal echocardiography codes, which are 93312 and 14. There's also 15 and 17. Those are really the accompanying codes that you would have with your 93319. You cannot report 3D rendering codes with the 70,000 series, which are your 76376 and 76377 codes, or the electrocardiography codes, which are your 93325 and 55. So again, if you're doing anything with 3D around echocardiography, take a look at this section, make sure that you're understanding the use of this add-on code, and then also the prohibition of some of the codes in which it can no longer be reported with due to unbundling reasons. Cardiac ablation, there's some new parenthetical notes that indicate the 3D mapping of the left arterial pacing and recording, those are actually now bundled. And there's also a new cardiac ablation table, which lists the elements of the cardiac ablation procedure, and it identifies services that are going to be inherent to the procedure. It will also list in that table those codes that are bundled, and also situations when they can be unbundled, when they are only performed independent and by themselves on rare occasion. Intercardiac echocardiography, also the autonomic function testing, both had some existing parentheticals that were revised. And then category 3 was added. The new codes are listed here for those new category 3 codes. And so those category 3 codes, again, based on new technology or new procedures, will be introduced in category 3. They will either later be adopted by the AMA to be put into a category 1 code and reassigned a code, or they will drop off. So those, that really wraps up the overview, fairly high level. These are kind of difficult webinars because chances are you're only going to be coding in a particular area. So it can be a little bit confusing in some cases, to be listening about cardiology if you're in family med, et cetera. But hopefully the high level overview of the category updates was helpful, and it may prompt you to look a little bit further within the code book around some of these changes. So with that, I'll pass it back over to Courtney, and we can open it up for any questions.
Excellent, thank you. So we are open for questions. If you can utilize the Q&A icon at the bottom of your screen, submit those questions. I will give it a few minutes, and then Joe, if you'd like, I can read them to you if it's more convenient.
Sure, yeah,
okay.
Yeah.
Okay. So it looks like our first question is, are there limits for the time period, months, that a patient can be on remote patient monitoring?
As a general rule, no, but you would want to look to the payer to see what is the condition of coverage and what they determine to be medically necessary for that particular remote patient monitoring, because it can vary based on the service. So there could be some restrictions by the payer based on what the remote monitoring is.
Okay. And what about changes to surgery codes?
There was a few. I don't have, there was 30 new codes that were added. When I went through that section, I don't recall, I mean, it's a fair amount of codes that were updated, but I don't recall anything that was really particularly huge. Some of this, what's happening is cleaning up some of the sections, but I don't recall specifically for surgery around that.
Okay.
Keep in mind, we had like 400 changes, so.
Okay. Thank you for the great info. And can you address some info on balance billing and other billing issues as well? I will ask a more specific question if you can.
Sure. So as a general rule, if you are in network with a provider, meaning that you have entered into a contract with a payer, there will be hold harmless clauses typically in those standard agreements in which you can only hold the patient financially liable for the in-network deductibles, coinsurance, and copays. Outside of that, anything that the insurance company would not pay, you would be prohibited from balance billing, and you would be in breach of the agreement or the contract. If you are out of network, there may be some balance billing pathways, if you will, but keep in mind, depending on the state that you're located, you may have a state law that will prohibit balance billing in some situations. Effective January 1 of 2022, the Federal No Surprises Act becomes law, which those states that do not have balance billing protections will be subject to federal law, and those states that do have balance billing protections will also be subject to that law as well. But essentially, what the balance billing protection law does, whether it be state level or federal level, keep in mind there's some variations, is there's going to be a notice and consent requirement. So if a patient comes into the ER, you cannot issue a notice and consent and have them waive their rights to be balance billed. They will have protections absent state law effective January 1st under federal law, but you may have protections already under your state law. Also, if you have a scheduled visit and the patient is, and you're out of network with that particular carrier or the insurance, then there is a notice period in which you need to provide a particular notice and consent. And if you issue those properly, meaning that Dr. Courtney would be the doctor that is listed with a good faith estimate amount of the charges that were anticipated to accrue, you're on your way to having a valid and enforceable consent should they sign. But if you put ABC Medical Group, that would be considered invalid and you can't do that. So there's some rules around consents. Federal law requires you to have them in 15 different languages for your region or your state. Again, your state law may have some variations. Those have to be retained for a minimum of 7 years from the date of service. And you have to issue them. Again, your state law may have, like in Michigan, our state law is 14 days in advance of the service. For federal law, I believe it's 72 hours or 3 hours if it's inpatient. Why would a patient want to sign a consent waiving that right? Maybe it's a specialist that they really want to see who treats this particular condition, and they're okay with being responsible for the portion for which their insurance doesn't pay. So there's reasons around that. So that's kind of a high level. So I don't know if I've answered your question on that, but.
Okay. It looks like we have one. Does the No Surprises Act apply to private physician offices?
Yes.
And can a physician practice charge a patient cash if they have coverage, but reimbursement is low?
I'm not sure what you mean by charge them cash, because usually it's going to be in reverse. Your charges will be your charges and how you accept payment. So if you are out of network, you could accept payment at a cash discount. If you are in network, you're going to be bound to the terms of the agreement.
So far, that is the end of the questions. So I'll just give it a couple minutes to see if any more come in.
And so I'll add around the balance billing. If you have a situation where the patient is protected by those balance billing provisions. So maybe they came in and they had a colonoscopy done and you're an anesthesiology group, but you're out of network. You cannot ask the patient to waive the right. They had no ability to consent to that based on the situation. So you cannot balance bill the patient because they would be protected by those balance billing protections, either state or federal or both. The only thing that you could collect from the patient would be any ordinary in-network amount for that particular service. So if their deductible for in-network is maybe $200 or their copay is maybe $100, that's all you can collect from them.
Okay, so I don't see any further questions. So this will conclude today's webinar. And I would like to thank everybody for attending, and a huge thanks to Joe for his presentation. And this will be posted on our website. And I hope everybody has a great day. Thank you.
Great, thank you.